Good afternoon, everybody, and welcome to today's webinar. Today I'm going to be talking about lessons learned from one of our EQA schemes for molecular testing in lung cancer solid tissue samples, and this relates to the activities we carried out in 2025. My name's Simon Patton. I'm the Chief Executive of EMQN CIC, and this is a non-promotional webinar, so it's really intended for the benefit of scientists, molecular pathologists, and our EQA scheme participants, to give you an overview of the activities we've been doing in this sector. Next slide, please. So I have the dubious honour of presenting myself in terms of background. So I'm a molecular geneticist by training. I've got a PhD in population genetics, but really my focus on quality assurance has been the last 30 years of my career with my work through EMQN. I've got an extensive background, if you like, on clinical healthcare diagnostics. And my key driver for me is my passion to make sure we have equity of access to high quality, accurate genomic testing for all patients, no matter where they are in the world. EMQN itself started out as a European project grant in 1997. And as first part of that, we were part of the UK Health Service for a very, very long time, until 2021, when we span out just post-COVID and set up EMQN CIC as an independent company with the support of the NHS. Nowadays, we have about 3,500 laboratories working with us from about 89 countries. And most importantly, the activities of EMQN take place through the strong commitment of a 300 plus volunteer network of scientists from around the world who actually help deliver our activities. Next slide, please. So my disclosures. Next slide, please. Next slide, please. So I've just pulled together a few slides, a slide of the learning outcomes you can expect from this webinar. This is supposed to be educational, and so there is a lot of, if you like, learning and best practice that we can highlight from the activities of the 2025 EQA scheme. But also, most importantly, there is a Q&A session at the end of it. And although we haven't explicitly stated that at the start, please do submit your questions using the Q&A function at the bottom of your Zoom browser. I'll try to answer as many as I can within the time limits we've got. But please do try to make this interactive. It gets the best out of it for both yourself and myself as participants and the provider. So what you're going to learn today is really the key challenges and common challenges and areas of improvement we've observed from the 2026 EQA scheme. I'm going to give you some practical reflections to support quality assurance and best practice implementation in this field. I've got one very key slide at the end of the presentation, which talks about how EQA scheme participation improves laboratory performance. And then finally, I'm going to conclude with some key deadlines and dates for both this year's activities and next year's activities in this sector. Next slide, please. So as obligatory to all the presentations I give in relation to EQA, I'm just going to quickly run through the principles of what we're trying to do and the key points. So the key points from EQA, the clue is in its name, it's an external quality assessment. So we are acting as an independent organisation testing you, the laboratories. So we are effectively an exam board for laboratories. And therefore, everyone who participates with us gets the same material for each case. You test that sample, agnostic of approach. So we're not asking you to use a particular technology. We are completely agnostic of your approach. We're asking you a clinical question, and how you answer that question is really up to the laboratory. What we're trying to do is assess your routine testing approach to lung cancer testing on solid tissue samples. We ask that you return your results to EMQN. And most importantly, we ask that you also treat those samples as if you would a patient sample. It's always interesting to see the results in terms of looking at errors and performance of laboratories, and particularly in the context of the fact we ask to treat it as a patient sample. Many laboratories still do treat their EQA samples with more care than their routine clinical samples. And we'll see the results at the end to show you how well laboratories have done with respect to that test. most importantly, from a benchmarking perspective, your results compared to every other laboratory participating in the EQA, and therefore we're able to determine accurately your performance, both in your analytical component and in your downstream processes such as reporting and report format. So the advantage of working with in an EQA scheme is obviously it's an external measure of your service quality, but most importantly, and EMQN puts a lot of work into this. I think EMQN is really trying to drive improvements in education and training. So our EQAs are deliberately designed to be educational in nature and not just punitive. Nevertheless, I think we have to all acknowledge that EQA, the drivers for people participating in the EQA, part of the driver for that is regulation. And in some territories, the regulators do take very keen note of the EQA performance of a laboratory and can suspend testing if performance is not good enough. In many cases, that's driven by the accreditation process itself. Next slide, please. So this EQA follows a very strong format we've been working on for the last 15 years. So it's been supported by AstraZeneca for 15 years, which is fantastic. So a big thank you to AstraZeneca for making the access to this EQA unrestricted. It is the largest EQA scheme in the world for lung cancer solid tissue testing. This year we had 342 laboratories participating. In previous years, we've had up to 450 laboratories. So it's a very large EQA scheme to both deliver and therefore, more importantly, gives a really good reflection of real world testing in this space. If you're a laboratory, you have about 8 to 10 weeks to perform your analysis or routine analysis of lung cancer tissue testing. That includes a variety of different genes associated with therapeutic options for lung cancer. And then all the reports that you submit to us are then reviewed and assessed by at least 2 independent experts. And we were looking at your analytical accuracy as well as your interpretive and reporting accuracy. The aim obviously is to use samples that allow us to replicate this, effectively send the same genotype to everybody. So we tend to rely on a mixture of artificial FFP materials and some clinically relevant real tissue biopsies. We ask that you report those, the results of your samples in the normal clinical context, and that you use applicable mutation variant nomenclature. And then we can obviously assess the consistency of reporting with respect to the clinical referral we've given. Next slide, please. So looking at the format of this scheme, we offer it in two different variations, if you like, sub-schemes we call them. One scheme is a common, which is mandatory for all laboratories to take part in, is called Common Biomarkers sub-scheme. And that's really mandatory for any laboratory doing EGFR, KRAS, and BRAF testing. So they're the 3 mandatory genes. The other sub-scheme, which is optional, is for new and emerging biomarkers. And although the EGFR and KRAS genes are mandatory within that context, we also offer testing for HER2, ERB2, MET, and now TP53 in 2025. The samples themselves are all FFP format, so we send scrolls, not slides. We use engineered lymphoblastoid cell lines manufactured specifically and bespoke for us by Revity in the UK. And the case structure of the EQA itself, each of the sub-schemes is divided into 5 cases. The first case for each sub-scheme is a full clinical case, so the laboratories will be asked to provide not just a genotype, but also the interpretation and reporting of the result. And then the following 4 cases are all genotyping only. So we're just assessing the analytical accuracy of the laboratories. As per all of our EQA schemes, we put a lot of work up front to try and make sure we're sending samples that work effectively and deliver the right genotype. So we validate all samples independently up front. We used 2 different laboratories this year. One laboratory was the internal laboratory of the manufacturer, and another laboratory used a Thermo Fisher Oncomine derived Amplicon set on the Iron NGS platform. Next slide, please. As I alluded to at the start, we work with a large number of volunteers from around the world who help support our activities. And our assessment process for this scheme utilises a set of predefined harmonised marking criteria. We had a team of 22 assessors from around the world, from 8 different countries, shall I say, who helped deliver this EQA scheme. You can see them defined on the diagram below. If I think in all cases, if you talk to any of those assessors who did help deliver it, they'll say how educational this being involved in this whole process is. It's always endlessly fascinating seeing how a laboratory can report the same result in multiple different ways, and no two laboratories use the same format or report the same result in the same look and feel as you would do. So there's huge variation between the laboratories and how they report it. And it's always an educational activity to take part in it. So if you are interested in working with the EMQN in future as an assessor, then please do go to our website. You can see the link here, the URL gives you access to a application form, but most importantly, it also defines the benefits of actually working with the EMQN as an assessor and what you will get out of it, both for yourself and your continuing personal development, but also for your laboratory. Next slide, please. So starting to look into the details, so this obviously is a very large EQA scheme. You can see the numbers this year were slightly higher than 2024, although we're still some way off the peak of the EQA activity in 2020 to 2023. But nevertheless, a large number of laboratories, 350 plus laboratories participated this year. And if we look at the participation figures between new and existing scheme laboratories, you can see that about 80% of laboratories, just over 80% of laboratories, have previously participated in the EQA. And every year we have about 20% of laboratories who are new to the EQA. Looking at the detailed data or breakdown of the geographical regions, the key thing here is there's not been a huge amount of variation between last year's data and this year's data. So the countries of origin, if you like, are quite stable for both sub-schemes of the EQA scheme. There's been very little fluctuation between the different regions or the laboratories participating from those regions. Next slide, please. Right, I'm going to now break down some of the lessons learned from the various sub-schemes, and then I'm going to come back to it at the end with the key learnings from combined from all of the EQA schemes. So let's take the first sub-scheme, which is the common biomarkers sub-scheme, which is mandatory for all laboratories to participate in. Next slide, please. So we had 359 registrations for this EQA, and 10 laboratories withdrew, and a further 11 laboratories didn't submit any results. That left us with a total number of laboratories participating in this sub-scheme of 338, of which 166 of them took part in this common biomarker scheme version only. So in other words, they didn't take part in the new and emerging biomarkers option. When you look at the breakdown of laboratories by different countries, you can see that just defined on the schematic, the graph on the right-hand side. You can see the three countries with the highest participation were China, Italy, and Spain. And then a broad range of laboratory participations from across the globe on top of that. Next slide, please. So starting with case one, remember case one was the full interpretive EQA scheme case. So all laboratories were expected to not just do the genotyping, but also report and interpret the clinical referral in the context of the genotype they'd found. So in this case, there was a lady who presented with stage 3C non-small cell lung cancer. She was a non-smoker. She'd had chemotherapy to help reduce the burden of tumour, and a section of her adenocarcinoma had been biopsied and taken for testing. And the clinician is requesting testing for EGFR, KRAS, and BRAF to determine her eligibility for targeted therapy. In this case, the sample contained a KRAS variant, P in codon 13, so P-gly13-cis, and no clinically relevant variants were expected to be detected in EGFR or BRAF. And the rationale for this case, quite unusual, but it's one of the reasons why these EMQN's activities are educational. We were trying to test a very specific scenario here. So we had a routine referral for a KRAS with a KRAS variant, but there's no clinical actionability associated with that particular KRAS variant. So this case was actually included to determine how a laboratory would interpret it in the context of therapy, for which there is no currently available direct therapeutic relevance in this clinical setting. In other words, G13C is very close to a clinically actionable variant in codon G12. So we were really testing how laboratories detect and interpret the G13 variant versus a G12 variant in KRAS. So next slide, please. So looking at the analytical results from laboratories, so the take-home point message here is the very low number of critical errors, which is great to see. So about 1.51% of all the tests led to a critical genotyping error. And when you look at the breakdown of errors, there were 2 errors associated with laboratories reporting a false negative and a false positive result. So in those cases, both laboratories failed to detect the G13 variant in KRAS, but one reported a G12 variant. So again, that's one of the questions we were trying to test. And one reported a different G13 variant, so P.gly13asp instead of gly13cis. And there were a further 3 laboratories who reported a false positive result. So they correctly identified the KRAS variant, but one laboratory reported another G12, or this time a G12C variant in a G12 serine variant, in addition to the correct G13 variant. So 2 laboratories did that, and then one laboratory incorrectly reported another a G12 or a G12 aspect, so 2 different G12 variants essentially, probably using a technology that couldn't differentiate accurately between the 2. Looking at the breakdown of the marks, so 81% of laboratories achieved a full score for this case. Several laboratories using a real-time PCR assay were unable to detect the variant, and that really, I think, reflects in that last false positive result. Although in most cases, we will take that into account in the assessment process. So clearly, in this last case, may well be an example where a laboratory hadn't clearly defined exactly what test they'd done and its limitations. But most importantly, I think this is really highlighting why we recommend laboratories are able to use a testing strategy that's able to uniquely identify all clinically actionable variants in KRAS, including G12C, but in this case, obviously G13C as well. So again, this was a deliberate case to try and see how well laboratories are able to differentiate between those 2 very closely related variants in KRAS. Next slide, please. Looking at interpretation, there were no critical interpretation errors, which is fantastic to see. Just under 60% of laboratories achieved full marks, which is a little less than last year. So 67% of laboratories achieved full marks for interpretation. And the assessors fed back that the quality of the interpretations was pretty good, but there was often a lack of completeness. And I think in the context of this referral, where laboratories have found a KRAS variant, and quite frequently obviously discussed as associated with that, the clinical implications or lack of the EGFR and or BRAF results were often omitted. And from a reporting perspective, laboratories really should ensure that all the relevant biomarkers that have been tested are addressed in the interpretation section, irrespective of whether they have a therapeutic impact or not. So again, really, the report should contain the results of all the genes tested, and people shouldn't be omitting the genes where you haven't found a variant. Likewise, the assessors were very keen to emphasise that the clinical report should be tailored to the patient as well, and their specific results, with no extraneous information included, which can often be confusing or lead to errors in patient clinical management. So several reports, for example, discuss the relevance and therapeutic options of G12C, despite this variant not being present in the sample. So again, it's really about making sure your report is clear and contains all the pertinent information related to that test, whilst at the same time doesn't include a whole raft of additional information or generic interpretive comments. Next slide, please. Okay, cases 2 to 5 were the genotyping only cases. So this format is replicated for both sub-schemes. So of these cases, we were expecting laboratories to find a BRAF codon 600 variant in sample 2, no variants to be detected in sample 3, a KRAS G13C variant in sample 4, in fact, the same variant, just a slightly different variant allele frequency, and an EGFR sensitizing variant, G719S, in sample 5. All the variants in this case were present at a frequency which should be detectable using the majority of different clinical tests that are used for lung cancer solid tissue testing. And the rationale with all of these cases were routine clinical referrals. So we were expecting laboratories to be able to pick up the variants in these different clinically relevant genes. Next slide, please. So looking at genotyping, I think the genotyping reflects case 1 as well, so pretty good across the board. The highest critical error rate was for case 4, but in all cases they were less than 3%. For the different cases, most laboratories got full marks, so vary between 81% and 87% of laboratories getting full marks. And when we look at the critical errors associated with the different cases, there were 5 critical errors for case 1, all of which were false negative results. There was one critical error for case 2, which, don't forget, is the wild type sample with no variant. So in other words, the error was a false positive result. For case 4, which was the KRAS variant that was being included in case 1 as well, there were 8 critical genotyping errors. 3 of those were false positives, 2 were false negatives, and another 3 were false positive and false negatives. In most cases, they picked up the right variant and reported a different additional variant as well. And finally, for case 5, which is the EGFR variant, sensitizing variant, another 5 genotyping errors, 4 false negative and 1 false positive and false negative. Next slide, please. So the key thing with this EQA scheme is obviously we're sending the same sample out to every laboratory, and we didn't detect any systematic errors with the laboratory processes or technologies used. And again, that's a very important part of why an EQA scheme is so valuable, as it is very powerful at picking up systematic errors with approaches and technologies. So let's have a look at the new and emerging biomarkers scheme. Next slide, please. So this scheme had 172 laboratories out of the 338 laboratories that participated across the board. Next slide, please. So EGFR and KRAS were still mandatory in this component, but the ERB2, which is the HER2 locus, MET and TP53 genes were optional for laboratories to test. And this year, TP53 was new to this EQA scheme. So whilst it's not strictly relevant for targets, it's not strictly a targeted therapeutic biomarker, mutations in TP53 are acknowledged to occur in at least 50% of non-small cell lung cancers. And therefore, it remains a valuable biomarker to include and to test. It's got a high prognostic indicator status. So many more aggressive cancers have TP53 mutations and therefore a poorer prognosis for the patient. TP53 mutations often co-occur as well with other actionable mutations such as variants in EGFR. And there is emerging evidence suggesting that patients with TP53 mutations may respond better to certain immunotherapies, so particularly immune checkpoint inhibitors. So a very relevant gene to include this year, and this year was the first time why we'd included it as a consequence of that background evidence. We included one variant for TP53 in case 10. So that was a codon 53 variant, cis 135 phenylalanine. And we also had actually a second variant, which was present in all of our cells because it's part of the background cell line. It's an endogenous variant in the background cell line. So a codon 215 variant, which was present at 100% variant allele frequency. We didn't assess this particular variant because it is a background variant within the background cell line, so it wasn't included in the EQA. But the codon 135 variant was included in case 10 and was assessed for laboratory's ability to detect it. Next slide, please. So case 6 was the full clinical referral so we were expecting labs to genotype and interpret and report it. So in this case, there was a lady who had been a long-time smoker. She'd had imaging and shown a mass on her left lung, and she'd also had metastatic cancer, so she got bone metastases as well. She'd had a core needle biopsy, and it showed adenocarcinoma, and molecular diagnostics is required to evaluate further treatment options, therapeutic treatment options. We were expecting laboratories to detect an EGFR exon 20 variant, a duplication, and no variant to be detected in KRAS, ERBB2, MET, or TP53. So we included this case, the rationale, because we were interested to see how laboratories would determine interpret the variant in the context of its resistance to conventional tyrosine kinase inhibitors, EGFR tyrosine kinase inhibitors, but also it's associated with sensitivity to this specific new class of drugs for exon 20 inhibition therapy. So a very relevant case to include and a relatively recent therapeutic option to test for. Next slide, please. So looking at the genotyping, overall, really done very well by all laboratories. There were only 2 critical genotyping errors that accounted for about just over 1% of all the genotypes tested. So one laboratory reported a false negative and false positive, so they failed to report the exon 20 duplication and incorrectly reported a KRAS variant in G12C. And the other error was caused by a laboratory failing to report the exon 20 duplication in EGFR. So they've just, and false negative, failed to pick it up. Just under 80% of laboratories got full marks for this case. And the key point of learning that the assessors wanted to get through to the laboratories for this case is that really how laboratories interpret this type of variant. So I know therapeutically that many people refer to it as an exon 20 insertion, but in fact, actually, from a nomenclature perspective, duplications actually take precedent over insertions. So strictly, laboratories should actually be referring to this variant as a duplication rather than an insertion. It's so easy to make this type of mistake, and more importantly, it's also perpetuated by the fact that much of the therapeutic options talk about EGFR exon 20 insertions, but strictly this type of variant is actually a duplication and not an insertion. Next slide, please. Looking at the interpretation, so 71% of laboratories achieved full marks, which is really good to see. There were 3 critical interpretation errors, just under 2% of all those of all the genotypes that were done, results in a critical interpretation error. One laboratory referred to the variant as being sensitive to anti-EGFR treatments. Another laboratory referred to a strong clinical significance of KRAS related to adverse outcomes in non-small cell lung cancer. Clearly, this was an EGFR variant, so wrong. And the other laboratory derived the wrong interpretation of the correct variant. So they did pick up the exon 20 duplication, but didn't make any reference to the option for targeted therapeutic options as a consequence of it. Next slide, please. So cases 7 to 10, these are the genotyping only cases. And in case 7, we were expecting laboratories to detect a KRAS G12C variant. 10.5% variance allele frequency. In case 8, we were looking for laboratories to detect an ERB2 variant in codon 755 at 9.2% variant allele frequency. Case 9 was the wild type sample, so we weren't expecting to see any variants in this sample in those clinically relevant genes. And finally, case 10 is the sample we'd already talked about with reference to TP53. So it contained a TP53 codon 135 variant at 12.1%. But it also included a sensitizing variant in EGFR at codon 858, so L858R, at 13.9%. So again, the variant allele frequencies are specifically chosen here to ensure that a wide variety of different technologies could be used to test the samples. And in all cases, the technologies should be able to pick up these variants if they're performing correctly. Rationale for testing, obviously, these are all routine molecular referrals. Next slide, please. So looking at genotyping, again, really well done. Very few errors made at all in these 4 cases. Case 10 was the one that started to catch a few more laboratories out. But overall, the errors are there are a very small number of errors made by laboratories, which is really good to see. And in fact, actually, the number of laboratories getting full marks was actually higher than the common biomarker scheme. So it varied between just under 80% and 94%. So really good to see. Looking at the errors themselves, one critical error in case 1, which is a lab that obviously picked up the correct variant, but reported an incorrect variant as well. Case 8, there were 2 critical errors, one false negative, one false negative and positive. Case 9, which was the wild type sample, 1 critical error, a false positive result. And finally, case 10, which was a little bit more challenging and included the EGFR and TP53 variant. There were 6 critical errors. 5 of those were false negative, and 1 of those was a laboratory who made a false positive and a false negative result. But overall, the genotyping results are really high quality. Next slide, please. So again, just as in case 1, we didn't detect any systematic errors with any of the approaches the laboratories used. And in one of my next slides, you'll see the huge variety of different tests that actually have been used in this EQA scheme. So no systematic errors, great to see. Of the laboratories that tested and reported results for TP53, so 101 laboratories out of 172 tested for TP53. 32 laboratories, or 31% laboratories, reported that codon 135 variant as a variant of uncertain significance. Whereas in fact, the clinical data suggests that it is a variant of likely pathogenic rather than diffuse. Next slide, please. So looking at the lessons learned from the aggregated data from the EQA scheme, first thing I'm going to focus on is the test strategies used by laboratories. And there was a huge number of tests employed in this EQA scheme. But looking at the breakdown of the approach used by laboratories, just under 60% of laboratories use an NGS-based approach. And 40% of laboratories used an RT-PCR approach. And the remaining technologies used were very small. There were a few laboratories using strip assays. 1 laboratory used a whole exome sequencing this approach, and 1 laboratory used a mass spectrometry approach. What's interesting here is that there is now a complete lack of laboratories using Sanger sequencing, which has in the past always featured in the test strategies used by laboratories. I think this is really good to see. I mean, what we're seeing is really laboratories moving towards next generation sequencing assays, which do allow you to test for the full range of different clinically relevant variants. So the move in terms of strategy is going in the right direction, and we're now seeing the laboratories moving away from technologies like Sanger sequencing, which don't have, for example, the level of sensitivity necessary for picking up low variant allele frequencies. Next slide, please. So looking at the strategies used by laboratories always blows my mind because there's just such huge variety. So from this EQA scheme, there's 1 EQA scheme, 350 plus laboratories. There were 34 different CDX manufacturers used, 96 different assays used from those 35 manufacturers, 480 instances of assays used. So what this is saying is that many laboratories are using more than one approach to answer the question in the test of the EQA, and a further 18 different laboratory developed tests were also to also use. So massive variation, massive variety in approaches, but as emphasised on the results from both the sub-schemes, no systematic errors associated with the approach. So despite the big variation in laboratory assays, actually the quality of testing is really good. And that shows that the validation process in-house by laboratories is pretty robust. And we're not detecting any systematic problems with different approaches. Next slide, please. So looking at the participation and performance data, I'm just reminded by the host, so please do submit your questions on the Q&A section at the bottom. I'm looking forward to getting some questions to answer. So looking at the participation data, the graph on the left-hand side shows the participation data broken down by laboratories that submitted results and those that didn't submit results or withdrew from the EQA scheme. And the most noticeable thing here is that more than 90% of laboratories that participated submitted results to the EQA. And you can see there has been significant variation and fluctuation over the years. But in 2023 was the first year that we started to charge a small participation fee for laboratories rather than making the EQA scheme completely free. And the data here reflect the fact that the cost of an EQA scheme focuses the mind of the laboratory on ensuring we do get results back. And it's great to see that high levels of compliance and data submitted for the EQA scheme. Looking at the assessment scores, remembering that we're evaluating genotype, interpretation, and clerical accuracy and reporting. We're not including the latter category here because there's huge variation. But the genotyping and assessment score, interpretation scores are pretty consistent, particularly genotyping. So a laboratory gets 2 marks if they get everything correct, and they get a deduction from 2 marks across the board if they've made a mistake. Looking at the mean scores for genotyping, the mean scores for both sub-schemes this year were over 1.8, which is really good to see. So, and we'll talk about that in a minute. Interpretation obviously is much more subjective because we are assessing the laboratory's ability to report the genotype, often in a language that's not native to, that you're not a native speaker to. And although we've broadened out the context of the laboratory, what laboratories can report, languages can report in, up to 6 different languages now, clearly that doesn't account for every laboratory. So many laboratories do have to report in English, for example, which may not be their native language. And because of that, we do see a significant variation in the quality of interpretation, but it's still the data this year are aligned, if you like, with the data from previous years, which is good to see. So we've got consistency across the years. Looking at the critical error rates, so the critical error rate this year for the common biomarker scheme was close to just under 5%, and for the new and emerging biomarkers was about 3%. That's not inconsistent, should I say, it's consistent with the mean error rate we would expect to see for an established EQA scheme. So whilst a new biomarker, you can expect to see up to 25% of laboratories make a critical error. Once you get to routine testing like this, the mean error rate is around about 3 to 3.5%. So the genotyping errors are fluctuating between the two, depending on the sub-scheme, but are within what we'd expect to see for an established testing strategy. Looking at interpretation, there were a very small number of interpretive errors this year, and only on case 1 for the new and emerging biomarkers. So again, a low rate of error for interpretation, which is also fantastic to see. Next slide, please. So this is really the slide I want to emphasize to all the laboratories, the value of and importance of why you should be doing EQA regularly. So this is data from this lung cancer scheme, looking at the looking at trying to understand whether there's the correlation between the number of times the laboratory participates and their scores and their likelihood of making an error that could cause patient harm. So in the left-hand side, you've got the average score for the genotyping and interpretation categories, stratified by the number of times the laboratory participates. So on the left-hand two columns, the labs that participated just once in 10 years. The right-hand two columns are labs that participated every year for 10 years. And what you can see is statistically, there's a significant increase in performance of laboratories that participate regularly. In other words, those laboratories that participate every year have a higher scores for genotyping and interpretation compared to those laboratories that only participate once in that 10-year period. Most importantly, though, if you look at the poor performance of laboratories based on the number of participations, the data is very stark that those laboratories that participate once have a significantly higher chance of achieving poor performance compared to laboratories that participate every year, or at least regularly, at least routinely every year. The data therefore shows that the regular participation in EQA can lead to measurable improvements in laboratory performance. And we consistently observe increased or improved average performance scores over time and reduced rates of poor performance over time. So just really emphasising why it's important to do these EQA schemes annually, or at least regularly, and preferably annually, to really drive home the improvements in performance. Next slide, please. So my last few slides, 2 or 3 slides, is really about the other key learning points from the EQAs. So looking at the genotype, we'll take the genotyping to start with. The genotyping this year was really high. Great to see. So the average genotyping error rate was 3.4%, which is in line with what we would see from nearly all of our EQA schemes across the board. So really good quality testing from laboratories. So in other words, this is it should be. It's a very well established molecular test for lung cancer. Here, a couple of areas for improvement that the assessors have highlighted within the report is that laboratories should always include the results of all the genes they've tested within the scope of the EQA scheme, and not omit the results for genes where no variance has been identified. I gave you evidence of why that's important in both the different sub-schemes. They have obviously recommended that, we have to acknowledge there are different practices in different regions, but there is an alternative way of describing that if necessary, if your strategy doesn't allow for that. So we also recommended the laboratories including a statement where it says no other clinically actionable variants were detected should be included if a variant has been detected. So in other words, just making sure that the reader can see that you've tested more than just the gene where you found the variant. We continue to recommend that laboratories that have missed clinically relevant variants due to the limitations of their test consider using another method that has a higher level of sensitivity or broader scope, for example, next-generation sequencing, and don't limit their analysis to hotspots. Obviously, the importance for a patient here is that it does broaden treatment options for the patient. And we are seeing that, as I alluded to earlier, a real move for laboratories using these types of technologies. So there is a change taking place within the testing community, and a move towards using next-generation sequencing-based approaches which do meet that need. Finally, whilst I know that the interpretation of variances can be clinically difficult, we have taken the move in the last couple of years to recognise the MAIN initiative, which is taken over from the LRG variant reference sequence initiative. But we also acknowledge that it's still not fully employed yet. And so we would encourage laboratories to make sure that they use, where possible, the clinically relevant MAIN transcript, either the MAIN Select or MAIN Plus clinical, to actually use as the reference point when they're interpreting the variants they find in their molecular test. Next slide, please. So looking at interpretation, so the assessors want to highlight that the standard of interpretation is improving. and many laboratories now include an interpretation at the end of their report, and some reference to for the treating oncologist about the availability of all data and not just the mutation testing. So in other words, it's a much more comprehensive report, including the interpretation, than just the analytical result would have been in the past. The areas for improvement that they've highlighted is still a small minority of laboratories are not providing sufficient details on the limitations of their test, and some laboratories still continue to confuse analytical sensitivity with limited detection. And the clinical interpretation should be tailored to the individual referral reason, the patient being tested, and the specific results you obtain from that test. So we still continue to see a large number of laboratories using a generic interpretation process, regardless of the genotype they found. Obviously, the relevance of tailoring that result to that patient and that referral is it means that it's much easier to ensure that you don't make a mistake in the interpretation, and it could, the patient gets the right drug. You're talking about the right therapeutic options within the context of the genotype you've found. So please do try to ensure that you, where possible, you are actually giving the tailored feedback to that individual patient themselves. Next slide, please. Looking at reporting, reporting is good, but there's, as I talked about earlier on, there is big variation in there how a laboratory reports the same result, and there's definitely still room for improvement. The key areas for improvement are providing some more comprehensive reports. So we still see a huge range in the overall quality of reports. Some are really, really good. Some are quite basic. We do have educational reports available. Should laboratories wish to see good examples of good practice, just contact the EMQN office at emqn.org, and we will be happy to provide you with copies of educational reports that you can use to help structure your formatting of your report. Multi-page reports are still very common, and one of the things we try to emphasize is the fact that it's often, when you start to have multi-page reports, the chances of a report or the pages of a report becoming separated are significantly increased in the reporting process. So if you do provide multi-page reports, it's absolutely essential to provide patient identifiers on all of the pages, and most importantly, also include pagination so the end user can see how many pages should have been included in the report. But I think one thing that's definitely improving is that we're seeing less, or fewer, should I say, long reports. And this year that trend is still continued. So in the past, we could have seen reports of up to 40 plus pages for the same test, whereas some laboratories are able to convey the same information, the clinically relevant information, in 1 or 2 pages. So massive variation in the past, but we see less of it now than we previously did see. So there is definitely an improvement in that perspective of reporting. Okay, next slide, please. So finally, I just want to end up on some key dates for the laboratories this year. The 2026 samples have, I think, already been shipped or just been shipped. So we'd encourage laboratories to make sure that they submit their results within the deadline provided. We aim to complete this tissue testing EQA scheme by the end of this current calendar year. If you have missed the registration deadline but still want to participate, just about time to do so. We could probably still get samples out to you. So please do contact the EMQN office as soon as possible to let us know. Next slide, please. And finally, the deadline for registration for 2027 EQA schemes opens at the beginning of September this year. So do keep an eye out for our catalogue launch in early September of this year. Next slide, please. Right, I'd just like to end on a few acknowledgements because this is, obviously I'm talking about this work, but it's not my work per se, it's the work of a very large team of individuals. I'd particularly like to thank Mel and Arthur from my team who run the molecular pathology EQAs, but most importantly, the scheme organisers and assessors and the scientific advisory group members who've contributed to the delivery of this EQA scheme. As you can see, 22 members of staff, 22 volunteers from around the world have really contributed their time to delivering it. And I want to make sure there's a big thank you from me to you guys for helping to support EMQN continuously. Okay, I think that's it. Next slide, please. So we have a few minutes for some Q&A. So I'm just going to go to the Q&A and see what we've got. Okay, so we've got a question here on, it says, regarding the classification of detected variants, should the classification include both the effect of the tumour biology, so the oncogenicity, and the clinical significance? Should the term oncogenic be used over the term pathogenic for genes such as TP53? So a very good question there. So when coming to reporting, I think I guess the real clinical context here is that what the report has got to convey the meaning of that variant with respect to the therapeutic options for that patient. And obviously the example we used here was a TP53 variant, which doesn't include a therapeutic option. So if you detected a variant in a gene such as TP53, we would expect to see the laboratory report the oncogenicity, if you like, and the clinical significance of it. So clearly there's no clinical significance here, so you could easily say that. But it was clearly also a variant that was likely pathogenic versus a VUS. So we would expect to see that reported in the report itself. It was also present at a variant allele frequency, which clearly indicated it was unlikely to be germline in origin as well. So again, that the report should contain some mention of the likelihood that it was a somatic variant rather than the germline variant. But again, there are massive ways, there's considerable variation in how laboratories do this, and the assessment team will take that into account in the assessment process, and we have marking criteria to be able to do that. Okay, looking at the Q&A, if there's no more Q&As, any more Q&As, I'll give it a minute or so if you've got any more questions you wish to ask. Okay, it doesn't look like we've got any more, but if you do want to submit a question, please use the, I think you would have received an email from the host, or you can always email office@emqn.org with a question. I'm happy to consider all questions even after the webinar is closed. Finally, just want to say that this webinar is being recorded, and normal practices, it takes about 2 weeks for it to go through compliance, and we will notify all laboratories that participated in this webinar and also put it onto our LinkedIn and mailing lists afterwards when it's available. So it'll be available probably in about 2 weeks' time on our EMQN YouTube channel. So in the absence of any more questions, I'd like to thank you for dialing in, to thank the organising team and AstraZeneca for helping make this webinar a reality, and most importantly, thank you, the laboratories that take part in the EQA for participating with the EMQN, and we look forward to you working with us in 2026 and 2027. Thank you very much indeed, and have a good day.